Present in over 70 countries, with 10,000 plus employees, 9 world-class manufacturing sites. Research-driven company with complex R&D capabilities. More than 500 qualified scientists, 13 chirally pure molecules, 5 biosimilar. First in India innovative products. MCure's mRNA vaccine Phase 1 trials have started with funding from Department of Biotechnology, Government of India. MCure Corporate Initiatives. M Gurukul, India's first mentor-mentee program for doctors. Uncondition Yourself, first of a kind revolutionary talk show on women's health. M Vidya, a knowledge enhancement series for nurses and paramedics, in collaboration with Symbiosis College of Nursing, with 12,000 plus paramedics across 3,500 plus nursing homes. M Diva, MCure in association with RSSDI aims to promise better women healthcare in India. AnemiaFreeIndia.com, an initiative of FOGSI and MCure to spread awareness about anemia in India. Stroke Care App, an app towards stroke awareness for patients. BreastfeedingIsGood.com, an MCure initiative to promote breastfeeding awareness in India. At MCure, science wins.
When was the last time you heard women openly talk about their mental and physical health? Menstrual disorder, diabetes, pregnancy and breastfeeding, depression, cancer, infertility and safe abortion? Don't remember? Well, that's because the stigma attached to such conditions has forced women to bear the pain in silence. Dismal statistics on women's health need to change. A difference cannot be made until they voice their opinions, put forth their stories, and together bring about a healthy change. Presenting Uncondition Yourself, India's first of its kind revolutionary talk show dedicated to women's health. A platform where we talk about their health issues and breaking taboos. Catch Namita Thapar in conversation with leading doctors and patients sharing candid stories. It's time to speak up. Together we can raise awareness and create an impact. Subscribe to our YouTube channel for more such videos related to women's health.
A very good evening. I, Dr. Nilesh Balkode, welcome you all to this FOGSI webinar series on COVID-19 and women healthcare. We have been witnessing hard times these days and it's a difficult situation all around us. And we need to find a way out of this to lead all this humanity to a destination where we all are safe. And so is the efforts behind all this by the FOGSI President and Secretary General of FOGSI. Success is no accident. It is hard work, perseverance, sacrifice, and most of all, love of what you are doing or learning to do. So these two duo have done a wonderful job in the last year, and we all appreciate that, the Herculean efforts taken by them. I bring to you the message by FOGSI President for this webinar. He states, as India faces a second wave of COVID-19, various measures have been implemented to combat the spread of SARS-CoV-2. The emergence of new variants has made the situation more difficult. Experts have advised the use of double masking to strengthen the fight against COVID-19 along with vaccination. Therefore, it is important for frontline workers to know all the aspects of double masking to make their patients aware of the preventive measures in this crucial situation. And that's why this program. Thank you. I welcome the chairpersons and the faculty for this program. We have none other than Dr. Alka Kriplani Madam as our esteemed chairperson, and we have 3 distinguished faculty which will be introduced by Alka Madam. Can we have Madam CV, please? Dr. Alka Kriplani Madam, as we all know, has a humongous career and she has led different organizations. She was the president of FOGSI in 2016, president of JESI, 2011 till now, President of
They can cover the
Delhi Gynecological Endoscopic Society, President of the Delhi Association of Obstetricians and Gynecologists. She is the editor of Asian Journal of OBGYN. She is the co-chair of FIGO Menstrual Disorder Committee, and she has been awarded numerous awards, most important of which stands up is the Padma Shri, is the for awarded for the highest civilian award for India. So she has been awarded the BC Roy National Award and n number of awards. She has numerous lectures to her credit and also numerous national and international publications. We welcome you, ma'am.
Thank you so much for your kind words. It's an absolute privilege and pleasure to be in this symposium because I think nothing else is more important in the academics than COVID today. We all are suffering, everybody is suffering, and our life has changed because of COVID. Presently, we are not doing any elective surgery because of the second wave is really worse than the first, and elective surgeries are off. Life has totally off the track, and but I salute FOGSI, Dr. Alpesh Gandhi, Dr. Jaideep Tang, and you doctors who are really, it's a good idea. At least our spirits are higher when we are meeting each other. And I think this is a very, very pertinent topic today because last time and after few days, human memory is so poor. I'm pretty sure when the condition improves, we will again go to operate. So today's session is dedicated, as these people are doing for 1 week, every aspect of COVID is threadbare discussed. And today I think it is the operative and pre-operative things. And it's very, very important to know what is the progress, what are the do's, what are the don'ts for the COVID. So without wasting time, I would like to, shall I invite the first speaker?
Yes, please.
Dr. none other than Prakash Trivedi. Prakash Trivedi not only is a dear friend, there may be so many things written here about Prakash, that he has been heading so many associations. He is tirelessly working and doing, live workshops, teaching, training. I would like to say, dil se about Prakash. I'm a really big admirer of his because it's not only the teachers are in medical schools. See the amount of teaching he has been doing for decades and sharing knowledge. You invite Prakash and he will be there. See today also. So he will be there. He takes out time. He devotes so much of time, energy and effort to teaching and training that we really appreciate him as a teacher. And today he is going to tell us, let us see what he has to tell us about COVID. I know he has personally done so much of work for making surgery safe in COVID times. He had so many discussions with me off and on, what should be done, how should this gas thing, when there was overhype in laparoscopic surgery, that the gas will be a reason for COVID transmission. Then he conducted his original research. So we really appreciate and admire you, Prakash, and the time is yours. Please start your talk.
Thank you very much, Professor Dr. Alka Kriplani. We get stimulus only after seeing you. We are just following your footsteps. One of the greatest obstetrician, gynecologists, laparoscopists, you robotic surgeon, you name all the things Alka has. And pleasure to talk for FOGSI. Alpesh, Jaideep, Nilesh, then Rupal, and my very close friend Ramesh, who know from Bangalore. We'll try and share some of the things because as Alka Kriplani has rightly pointed out that things have changed. Because these talks we have given last year, 6 months back, today, and we'll give 6 months later. Obviously, I was just invited in one of the SIG group by AAGL, and that subject is also such that there is always controversy. So let's understand. Uh, there are two important aspects about COVID. Everybody knows COVID is a huge thing. So there is science of COVID, the politics of COVID, and the politics affecting good scientific people for COVID. But all said and done, a lot of mortalities are taking place and a lot of issues are there. In the first half, India was proved as somebody who was beyond everybody, and now it becomes that we are on the brunt of. So I focused on laparoscopic surgery right from March, because on 25th March, that was last March, there was Gudi Padwa day when I had to. Uh, 1 second. I had to do a cesarean section, and we went ahead and did. Now we have to understand that as humanity, we don't change our approach to anything. We come, we talk, we go back, go to sleep. Next morning, you're the same. So unless and until we don't change our approach, by by us, I'm telling, of course, doctors are definitely doing it. But then being part of the system of care, you're exposed to people who have not changed. And it's also wrong on politicians to only blame people, because if people were to take care of their own health and everything, then why we elect any government? So pandemic can affect humanity in a big way. And in a country like India, where the numbers can jump so fast, empires can come down, and there are a lot of new issues which have been discussed, and a lot of ifs and buts and possibilities. Now we started our work for a long time. We what started, because we used to have little higher number of abortions, voluntary. Certain aspects of obstetrics we had to do. IVF we had reduced. We had a patient of ectopic and appendicitis, so we had to do. Then, as usual, I started working because I heard everything, including guidelines published by many people, and so many webinars going on by American organization, European organization. In my mind, I was never in agreement with everything what they told. So we took this study, and now we have around 207 plus cases wherein various laparoscopic surgeries, including cancer surgery, bowel resection, hernia, uretrovesical anastomosis, and other standard surgeries have been done, both some for emergency, and this I want to emphasize, it is 10% for emergency and 90% wherein I understood that if I am not going to treat this female, which other hospital is going to accept her and treat her of a problem for which she cannot wait. Say if we would waited last time for 9 months, then again she would have had to wait for 9 months. So we had a different approach, and there are two major issues. One was general anesthesia. Fortunately, I've done a post in anesthesia, so I do understand a lot of intricacies about general anesthesia and anesthesia in general. So we knew obviously from anesthetist to patient and patient to anesthetist, it's a important issue. Then plume, smoke, and everything went on to such a huge level that most of the international organization favored laparotomy over laparoscopy. And the biggest statement which they were indirectly trying to tell, not directly, they were trying to tell, okay, you are in a small place, you are having BD. Why are you having BD? Have a cigarette. If you're having cigarette, why cigarette? Have a cigar. If you are having cigar, why not? Have a hookah. Hookah, why hookah? Have shisha. Why? Because all the smoke you will take in, we will evacuate that smoke. So you will not get lung cancer. I mean, one of the most ridiculous excuse I found for use of smoke evacuator, because this same smoke evacuator was given to me in 1995 when CO2 laser used to generate smoke. So I was pretty sure that smoke and worrying about the smoke and temporary taking care had no meaning. Obviously, HIV, HBsAg, and various other viral, blood-borne or respiratory-borne, we do operate. Very often we operate, maybe as a last case, throw away everything, then do the other changes. And somebody like Quack is the name, not the quack, had already reported that 10 out of 11 cases of hepatitis B, there were the material. But all that you had to do is you have to be careful. You had to take protection. You had to have special clothing, and you had to dispose each and everything, which we did for HIV, hepatitis, and in the past when SARS-CoV was there. So I started realizing that we should, in fact, there was a phase when evening consulting restarting was a discussion, because typically stopping laparoscopic surgery, we were not really convinced, because what method in the last video I'm showing, we are using it for a long period of time, understanding the issues, and fortunately it has come up well so far till date. So there is no typical close down. About oxygen and about beds, that's another issue. If I get a minute or so after my time, then I may share something on that also. Now, first of all, you have to have overall clear idea. See, when we had SARS-CoV first in March, everybody were in the Ppe Kit, everybody were at home, strict lockdown. You knew some patients have. In fact, that virus was less infective than the current one. So this is a little mutant wherein the infectivity is more, and this is more prone to your lung. And if it is more prone to your lung, it has more problem and more mortality. So the primary thing what we started initially straight away, you have to have an idea about what is the uh, incidence in your area or whichever area, because we get patients from everywhere. So our secretaries, though working from home, they used to have a quick questionnaire when anybody wanted to come and meet us. So a quick history was taken, name, etc., detail, any fever, cough, headache, diarrhea, any close contact or anybody who is going to come, details of that. Then any visit to hospital, diabetes, met any doctor, hypertension. So all those things were preliminary thing before even when they came and did. Obviously, if we had 3 hours consulting, it was only 6 patients. 4 hours consulting, it was only 8 patients. Because one patient is with one relative. So it is better that you finish. You can't do like, one is just going and the second one is coming out. First thing which we did, which was very important, each and every of our staff member were informed that we'll do the RT-PCR, at that time antibody test. Every member's tests were done at hospital expense. If there was a need, now recently we can do an antigen test, spread the duties. People who can come, who could not come were adjusted, the duties were modified. Somebody used to have triple duty, somebody was not coming, but we didn't cut their salary. Addition to this, what I have not written here, I had told that if anybody has to get admitted and has some expense, which may be up to 5 lakh rupees, then I will be bearing if it is an hospital staff who was at work, not sitting at home. Of course, when they come, sanitizer, SpO2, temperature, dry cough, it's small thing, and many people are asymptomatic. They're talking to you and SpO2 is 82. Spacing in your waiting room, and when they come to consulting room, also limited number, not like full family is there. Obviously, the patient who is admitted, all the investigations are done which are necessary. We have counseled the patient. There was a phase when we used to tell probably this is a good time when you can get operated because all the staff are here. We have taken due precautions. Roads are empty. This was few months back, or maybe in the last second half of the year and early this month. Now we withhold this statement, but what happens is there are so many people who just find it difficult because how long they can wait. So all patients who are admitted, all things are investigated. Nothing is left here and there, RT-PCR. Now, management of this patient is very clear. They come with one relative, both of them come, and they will go on discharge. So food, tea, coffee, this, that, etc., both of them is taken care of. So they are not supposed to go in, out. Everything is taken care, one room, one by one system. So all in hospital, there is proper sanitization of rooms, OTs, and staff which are sometimes nagging, but such staff are better because otherwise it really doesn't work. Now, this is a very senior OT assistant, was earlier in a very big hospital. So, of course, our standard precaution of sanitization, distance, mask, temperature test, and other thing, even prior to just doing. Now, we are gynecologists. I have 5 machines. I have ordered 2 more. So, we're going to have 7 machines. So, we're going to discard with a typical physician type of attitude like Ppe Kit and as if we are astronauts consulting, I started finding how much it was necessary. See, if you're operating, it is different. So we took due precaution. We have to do sonography. Fortunately, you finish everything in your own place without much crowding. Counsel the patient. See to it that nobody, our entire talk is on COVID negative. We are not talking of the moment they say tell COVID positive. We don't step there. We guide them where they should go, and accordingly, things are done. Obviously, in the operation theater, when in the earlier phase, we had no options but PPE kit, this, that, so many things. Each and every thing is daily sanitized. Then in gynec OT, you have your fumigation, IVF, modest, you can't fumigate. Uh, Obviously, there are a lot of things wherein you need positive pressures and so many other things. I always felt that open surgery was worse to contain smoke. And the second issue was tissue morcellation. So that we had to add, apart from bag, that what comes out of bag should not splatter. Something from suction should not splatter. So all small things. And very often we had to teach the people that when they're cleaning, they have to lift the energy source. You can't just lift from the top because there may be other things from below. Now, this is our important video, which will explain you most of the things. And we started realizing that the most important thing was anesthesia. Obviously, we understood that we have to do surgery, which may be semi-urgent or may be urgent. So we had an anesthetist who was relatively young, as the older anesthetist never came. So this was the hood which was originally advocated, and now there is a query whether it may be beneficial. Patient is kept deep, no surgeon is there inside. Only the OT assistant and the anesthetist is there. This is the video laryngoscope. Obviously, people find it very easy to do intubation without that also. But here there is proper documentation. And if you see an artery forceps is kept, so if she coughs or bucks, the thing doesn't come on the anesthetist's face. So once properly under vision, the tube is inside, patient is kept deep so that patient will not suddenly have any other issues. Once the tube is inside, the anesthesia filters are important. Once the tube is inside, the anesthesia filters, so they are connected with the uh, endotracheal tube, which is stabilized. The artery is taken off, and we call this as double closed circuit 3 filter technique. So these are the 2 filter, and as you can see, the gases which come from the anesthesia machine do not generate COVID, coronavirus. So it gets filtered through a filter which takes care of bacteria and virus. So it's an SME BV filter. There is another filter which is close to the endotracheal tube, wherein people who know anesthesia, it's for humidification. The one which is returning back also has a filter. So the CO2 which is going into soda bicarb, so machine is totally protected. It is entire one closed circuit with 3 filters. The hood is taken away. After all these things, the surgical team enters the operation theater and everything is ready. We change into an OptiView trocar because after creating pneumoperitoneum, quite often his hissing sound may spread. So if you can see over here, under OptiView trocar, you enter inside. The advantage with this was that number one, once you've entered, you will not allow the inner gas to come out. So you take out, because this is 1210, so you can go in and you can take out Obviously, when you use 3D, the hood ahead was a problem because your specs and hood negated the effect of 3D. So this now we have connected. So the gas which comes from the insufflator is also coming through a filter. So the gas from the cylinder to the machine cannot give any coronavirus. So it is already filtered. Then you put the secondary ports, which are essentially under vision, as we do normally. The right lower port has a three-way attached with a small pocket filter. I will tell you why that is there, because if there's little leak accidental, even then leak will not go. Now this is an important thing which is attached. This is the desufflation tube. So this goes into one of the endomat bottle where it dips below sodium hypochlorite, and the suction is then connected to the endomat machine. If you don't have endomat, you can use any other machine. So there is no chance of anything from the gas to actually spill into a normal atmosphere. The other ports are as usual as normal, and you can do surgery, whatever surgery you want. You also have to realize that we have to use suction. For suction, we have another endomat and another bottle, because when you're using suction, that's our suction. So when you're actually having some blood or tissue, the suction will go in the other tube, and it will go, and once that blood and all, it will actually go below the sodium hypochlorite. So the thing which is kept above sodium hypochlorite is not having any. So whatever tissue material is there, first of all, you remember that peritoneal cavity, COVID with macrophage does not tell, okay, I have come now, let me come out to peritoneal cavity. It cannot come unless bowel is open. So again, this is controlled by suction, wherein again the filters are kept. So the machines are protected, and all these things can take care. And everybody is guarded. If specimen was to be removed vaginally, then they use a hood. Now this is an opening which is done. For example, when you want to finish, so you will desufflate below sodium hypochlorite. So desufflation is a procedure which is not accidentally done. So it will be again done. Once you are finished, you will take out the optics, you will close the inflow, then that inflow tubing is kept away. Then this is opened up, the desufflation tubing. The bubbles till it disappears, so you know all the pneumoperitoneum is gone. This we are doing so that no tissue, cell, RBC, anything from the abdominal cavity will ever come in contact with external part of the OT. Once this is done, then you can remove all the ports. Once you remove all the ports, you can take stitch or whatever you are used to, whether you are any other method if you are using. The other important thing is, if you remember, we had the insufflation tubing. So after I have done this, the insufflation tube, see now there is no gas, so you can take it out. The insufflation tubing will have, the cylinder is closed, so any gas which was inside the pneumoinsufflator is now allowed to get drained into the sodium hypochlorite solution. So for the next patient, it is not that you have previous patients carbon dioxide which is kept. So your cylinder is empty. So till now it is all right. Now when you do tissue retrieval, this is a little tricky thing, because you have to use washers during your morcellator, leak proof. Once we have finished the entire morcellation, then through the central optics, we pass a 10 millimeter reducer and connect the desufflation tube or the suction tube and deflate the entire gas. There is a knot which is tied close to the morcellation. So the entire gas which was inside the bag, again, it's a fibroid tissue, cancerous tissue, uterine tissue, adnexal mass tissue. You can see the entire thing will totally disappear. So once this is done, then you will you can take out the morcellator and that port and the bag, The last and important point is the extubation is very important. By this time, the surgical team is gone. So now you empty the bulb of the endotracheal tube, disconnect the machine's connection, and see how properly Dr. Nilesh Gadge, our anesthetist for all this period of time, holds everything, and then he puts it in a container which is going to be disposed. The patient is kept deep so that patient doesn't vomit, but even otherwise, sometimes they may need suction. So you have to have a dedicated suction. All these tubings are to be disposed along with the filters. Have a separate suction, which is standard suction. So when they want to do some suction, for the prior to intubation or after intubation, again that goes inside this. So with this method, I think the adversity is the mother of all invention. With this method, we were happy that this got published, this got patented, and this got accepted. And it is a method which keeps patients safe, staff safe, machine safe, anesthetist safe, next patient safe. So we have to understand, we have to keep innovating. We had a thought that we may do for COVID positive patient also, but there's enough of COVID negative patient who need surgery and we can take care. I thank you all for a patient hearing, and I'm sure I must have added something to your knowledge. Thank you very much. Atul, how are you?
Hi, sir. Fine, thank you.
Something I got an idea. Anyway, pachi baat karte.
Yeah, we are having our chairperson, Dr. Atul Ganatra, sir, and welcome, sir.
Thank you, Dr. Rupal.
And so we are delighted to introduce our chairperson, Dr. Atul Ganatra, sir, and he is the director of Ganatra Nursing Home and Progeny IVF Center. He is the consultant gynecologist and endoscopist at Fortis, HMN and Jupiter Hospitals, Mumbai. He is the joint secretary IGE and vice president FOGSI for the current year. And he is also member of managing council of MOGS. And as a great laparoscopic surgeon and academician, he has been invited in various national and international workshops and CMEs as an expert as an expert and as a speaker, and have 7 international research papers to his credit. We are lucky to have you, sir, as a chairperson for today's session at very short notice, and we are very sorry to learn about your brother's untimely demise. And can I request Alka madam to start our second lecture?
I'll just take a minute, Rupal, to introduce Dr. Sangeeta. Is that okay?
It's perfectly fine, Atul.
Please, sir. Yeah.
So I said I wouldn't log in, but I had to log in because Sangeeta is one of the best anesthetists that we have at Fortis. In fact, we have a fantastic team. Dr. Prakash Trivedi is witness to the kind of work that we do, and we are very, very bold in Fortis because of the kind of team. Dr. Sangeeta specializes in transplant anesthesia and is one of the most humble, down-to-earth, and a cool anesthetist that I've ever seen. Thank you, Sangeeta, for joining.
Thank you very much, sir, for the kind words. And I must acknowledge FOGSI for this opportunity. Thank you very much, Dr. Ganatra, for giving me this chance to be on this platform. And I'm very sorry to hear about the sad news in your family. So please take care. Dr. Trivedi, sir, has given such a fantastic lecture. I am always in awe of you, sir, whenever I've heard you. And I didn't know that you have also qualified as an anesthetist. So truly speaking, you have actually covered most of the things that I was going to talk about. But still, I'll try and see what I can add to that. So please bear with me for this.
Sangeeta, you are the boss. I am just a student. So you share your opinion.
Yes, sir. So The topic was the anesthesia concerns during endoscopy.
Yes, please.
Everybody has been saying we are enduring this pandemic and multiple waves are coming down. We've been having the lockdowns in various forms, but we still continue to work as heroes. And part of the work that we do as heroes is endoscopy, which comprises of bronchoscopy and upper and lower GI endoscopies, laparoscopies, and even the robotic laparoscopy procedures. Keeping the COVID in the background, it is very important to remind ourselves about the physiological compromises that happen to a certain degree because of the laparoscopy. So please forgive me, I'm in a surgical conference, but I just wanted to put this across that the moment the pneumoperitoneum is created, there is an increase in the SVR. The diaphragm moves up and it makes it very difficult for the patient to breathe. And that is why often these procedures are done under general anesthesia. There is a degree of reduced gut perfusion. There may be vena cava compression, even a degree of cytokine release, a decreased preload, and a decreased cardiac output. Of note is especially the effects that happen on the respiratory system. There is a reduced thoracic and respiratory compliance. The FRC drops. There is atelectasis that happens. The peak airway pressures go up, and there is hypercarbia. So a patient who is already having symptoms due to COVID or pathologies is when subjected to the pneumoperitoneum would definitely be struggling. Once the IAP goes over 16 to 20, the effects that I had mentioned get exaggerated further. And this could reduce the bowel perfusion, increase the lung dysfunction, worsen vena cava compression, and contribute to the systemic worsening. So this is just in the background that I wanted to mention. There were studies to suggest that laparoscopy can lead to aerosolization of the COVID-19 virus. But like Dr. Trivedi said, really the evidence is not very profound. And actually, if you look at risk versus benefit, it is actually the laparoscopy which would provide much more benefit rather than carrying out an open procedure. It actually restricts the plume within the abdomen rather than allowing it to spread into the OR room. So we had to carry out certain generalized modifications in our practice, and every hospital entry was triaged, basically with a symptom check and temperature check. Each and every admission was tested for RT-PCR, and those who did not have a report were put in a sort of a suspect ward. Each patient was given a face mask to wear. Now for us, the challenge came for the PACs because we used to sit in front of the patient and do an airway assessment. And this was actually the cornerstone of our PAC. Now we were not able to do this, or we were doing this through screens and partly by telephone. So this was something that we had to adapt to. I'm not going into the details of the other PAC because actually Sir has already touched upon those things. So the rest of the PAC was completely the same. We had to look at the symptomatology of the patient. We had to involve the infectious disease department to decide whether or not this patient would be able to tolerate procedures. We ourselves were relearning medicine in a way. We had so many new diagnostic investigations that we were not aware of. We were not aware of the new CT scores that we had to know before we were deeming the patients fit for surgery. And guidelines were coming by the dozen. Every couple of weeks, we had to be updated with the guidelines for management of the patients. We too were struggling with communication through the barriers that we had to wear. Especially for the positive patients or the suspect patients. And truly we had markings, we had the names written over our suits. In the operation theater, the major problem was the aerosol generation. And so there were anesthetic procedures like the intubation, ventilation, fiber optic intubation, extubation. even CPR, and there were the surgical procedures which were aerosol generating. So what was done was the theater layout was relooked at, and we selected 2 operation theaters which were close to the entry and the exit, which would reduce the contamination if at all a positive or a suspect COVID positive patient were to be wheeled into the theater. As you can see, there was a separate donning area, and one of the OTs would then serve as a doffing area. Our OT pressures were maintained as positive, although there is a lot of recommendation to convert them to negative. It is not a very easy venture. You require to attach these very powerful exhaust fans, and therefore we were managing with the positive OT pressures. However, in the endoscopy units, that is in the bronchoscopy and the GI scopies, we were able to create a negative pressure system there. The HEPA filters as well as the air exchanges, which were about 25 per hour, were very useful in reducing the particulate content, and we could remove the 0.3 micron size. So that was a safety feature which was definitely useful. I'm really ashamed to show this slide. So Dr. Trivedi sir has given a perfect description, and I'm omitting this. The timing of surgery is still something that we depend upon our infectious control team to guide us by. So far, we were sticking to the 14-day rule, where a patient who has completed 14 days and then it became 17 days can be taken up for the surgery. But now, as more and more time has elapsed, the duration actually has shown to be around 7 weeks. And this is the latest publication that has come in the Journal of Anesthesia, where they are saying that the risk can actually be reduced to baseline in patients who underwent surgery more than or equal to 7 weeks after the COVID was diagnosed. However, if Ganatra sir comes in with a patient like this, and irrespective of the COVID status, we will take the patient up for surgery. And like Sir said, that the anesthesia concern, the first thing is your own personal protection. So the personal protective equipment has to be worn before the patient comes in, and the patient should never be brought into the operating theater complex and be made to wait outside. So the patient has to come directly into the operation theater. So this shows that we have a suspect patient who has come into the theater, but before everybody was ready with the kit. And we have a team present outside the operation theater as well in order to reduce the contamination. Whatever equipment is required in the form of drugs or other equipment is available inside the operation theater. This was the Ppe Kit that is available, and we are using this. It's very important to create your own sort of checklist, although a lot of societies have given their standard checklist, because your Ppe Kit may not be containing the same sort of ingredients that are present in theirs. And therefore, we prepared our own sort of local checklist, which was pasted in the areas of donning and doffing that could be followed by the person concerned. Now, like Sir said, the most experienced anesthesia personnel should be doing the airway manipulation, and you should use video laryngoscopes because they allow you to maintain a distance, and they also reduce the error or reduce the failed intubation attempt. Like he said, we have to use some form of intubation box or plastic sheet in order to reduce the spread of the aerosolization to the person who's performing the technique as well as to the surrounding people around. Now, it is easier said than done. The problems are that it may be very uncomfortable for the patient. It is very difficult to look through so many multiple layers of plastic and glass and then try and visualize the cords, even though you're having a video laryngoscope. And if you can see the distance or the height of those apertures in the plexiglass box may not be adequate for you to have enough room to move your hands to carry out the intubation process. Like Sir said again, you have to be very careful about how you're going to be holding the face mask. We were not allowing anybody to ventilate the unprotected airway. So the face mask comes on the face. You will not be ventilating. You're using a rapid sequence. So Spolin, which used to be reserved for only emergency surgeries, came into our routine use. We were conserving the flows. So flows of oxygen and air were shut off the moment we disconnected the circuit of the face. And use of double gloves was encouraged so that when we remove the blade out, it has to be covered and reduce the contamination. LMAs can cause leaks and aerosolization. So in the earlier part of the pandemic, say up to May or June, we were discouraging LMAs, but now we are using them quite normally. Closed circuits is a routine practice that we observe. And like Sir said, you have to have the HME filters at least on the expiratory limb in order to prevent the contamination of the anesthesia machine. Now this depicts how once an intubation is done, within 6 minutes of starting a case, these are the points of contact that are usually seen. Therefore, there is a very vast possibility of contamination of the workstation and the work surfaces. So you always must keep this in mind. Each and every action that you do has to be mindful. You must remove the gloves. You must use chlorhexidine before you have touched a surface and after you have touched the patient. One other problem that we were facing was that we were so used to having stethoscopes around our necks. And as soon as the patient is intubated, we'll auscultate the patient. Now, with the protective headgear and the tight fitting masks, it was very difficult to put the stethoscopes in the ear. And worldwide, they are actually recommending go back and look at the patient clinically, look at the bilateral chest rise, look at the EtCO2 to confirm the presence of the tube. And they're even recommending the use of ultrasound for the same. We are coming full circle, and actually now studies are showing that maybe anesthesia procedures are not generating that much of aerosols. So the intubation, rather than that, it is the extubation which is the problem because of the cough that can be generated. And the beautiful videos, I must really appreciate the videos shown, actually depicted everything that was required. You must have the minimum number of personnel in the operation theater before you even attempt extubation. The regular suctioning can be carried out carefully. Barriers again are recommended. The plane has to be kept deep. You have to avoid coughing. And as soon as you can, you need to place the face mask. The other thing is that the patient cannot be shifted out like normal into the recovery area or into the PACU for the recovery. The recovery has to be done by the anesthesiologist and the nurse inside the operating room. Once you're sure that the patient is fit enough to be transferred out, the patient will be directly shifted out to the respected ward. So the degree of contamination in the remaining operation theaters thereby is reduced. I'm coming towards the end. So the cleaning of the operation theater also is very important. You have to remember to keep the operation theater closed for about 20 minutes. Once the patient has gone out, with all the linen and the material inside, keep the OT closed for 20 minutes. Allow the HEPA filter and the air exchanges to remove as much possible particulate matter as possible. After that, then the housekeeping comes back in and cleans the floors and walls with 1% hypochlorite. The instruments are packed in a separate pack, which is labeled and sent to the CSSD department. As much as possible, disposable equipment is to be used. The soda lime breathing circuits filters are all discarded and changed. The bin liners have to be labeled as COVID positive, and you have to follow your routine biomedical waste segregation protocol for this disposal. So in conclusion, I must say that we go back to the SAGE's recommendation where laparoscopy is not something that can be forfeited. In fact, it has to be used because the benefits far outweigh the risks. But you must remember the personal protection. You must remember to do only the urgent cases. And I'm sorry. So this is our team at Fortis, and we send you our greetings. And yes, these are difficult times, but each of us can be a beacon of light. So please be a ray of hope wherever you can. And this is a family of friends. You can look it up on YouTube. Thank you very much for listening to me. Thank you very much.
Thank you, Dr. Sangeeta. It was a wonderful talk. And now I request Dr. B. Suresh, sir. He will be speaking on post-operative care and follow-up in COVID times. Yeah.
One second. He is Ramesh, not Suresh.
Sorry. I'm extremely sorry. I'm extremely sorry.
And one point before that,
Yeah.
the anesthesia team at Fortis is absolutely superb. Means all the difficult cases and 135 kg, etc. All I take, Sangeeta Shetty, Vijay Shetty, and so many. I always say that the surgeons are born because of the anesthetists, and they are the people who manage. You can introduce great Professor Dr.
I always feel that it is the, anesthetist who can kill or save the patient. Surgeon, if you cut something, you can fix it up. It is the anesthetist who really saves your patient.
Thank you, madam.
Yeah. So, Alka ma'am will introduce Dr. B. Ramesh sir.
Yes, sure. Am I supposed to introduce?
Yes, ma'am.
It's my proud privilege to introduce dear friend B. Ramesh, who is, holding the fort of endoscopy for decades in the city of Bangalore. His program, dedicated conferences that Rage every year he organizes, it's just the COVID who could break his, record. And he is pioneer in gynae laparoscopy. He is chairman of endoscopy. He used to be the chairman endoscopy committee and participated in and organized many, many conferences. He has performed 50,000 gynae laparoscopies, and he is visiting. I have personal experience of inviting and watching him operate in so many live workshops. He is a very, very talented surgeon and very dear friend and a very dedicated laparoscopic surgeon. So without wasting time, I would like to invite Dr. B. Ramesh. Please, Hello.
Sir, please unmute yourself, sir.
Ramesh, you're muted.
Share.
Unmute, Modi.
You can see, no? You can see it, yeah? Slideshow.
Yeah. I think good evening, everybody. Friends, Prakash. And I thank Alka Madam immensely for kind introduction. And all other, nice to see all other friends after a long time. Now, friends, I think Prakash and Dr. Shetty mentioned about the intra-op care very well. And the post-op care is often not taken so seriously, but it is very, very important. Let me tell you, it is as important as intraoperative care. Now let us see how do we care about these patients, whether it is laparoscopy or laparotomy. And there are two kind of COVID patients present in the post-operative period. Those who were positive during the operation or before the operation, and those who become positive after the operation or post-operative. So these are the two kinds of patients which we need to understand. And what are the purposes of the post-operative care? And post-operative, as you know, it itself is an immunosuppressant period, and the patient is under psychological stress and physical stress. So this is the increased risk of severe manifestation of COVID-19. If patient is already COVID positive, so she is exposed for all sorts of complications of COVID. And post-operative, mind you, however simple it is associated with significant morbidity and mortality. So one has to be very careful about the post-operative care of the patient. And so what is the purpose? It should be to enable successful, faster recovery of the patient, reduce mortality rate, identify the complications, reduce the hospital and patient cost during the post-operative period, reduce the length of the hospital stay and quality care services. So these are the purposes and general considerations. So only gynecs cannot manage the complete COVID care. You need multidisciplinary team, you need pulmonologist, you need physician, you need renal specialist, nephrologist, and intensivist. So minimal members with universal precautions. So post-operative ward should be occupied by minimal numbers, pre-planning and well-defined roles. Who has to do what job has to be defined before, and clear communication between the team members and social distancing. So sometimes the communication is through phones or online communication with the patient relatives and the doctors among the doctors. So it need not be direct. So all it can be, we have to use the technology to communicate with the patient relatives as well as with our colleagues. And so don't forget that you have already performed the operation, and the responsibility and the chances of getting infected by to the doctor, to the surgeon. So we must always keep it in mind, and we must use personal protective equipment during the procedure, during the post-operative rounds, post-operative care, etc. So all of you know that good PPE consists of gowns, masks, footwear. Don't neglect any of these items even during the post-operative care. So it is very important that you are as good covered as intraoperative in post-operative also. And now while shifting the patient after the operation, so you should take the shortest routes with the signage board. So you should not fumble in taking transferring the patient, especially in a bigger hospital. And the route should be evacuated, and transport staff with PPE. Don't transport the patient without PPE. The people and the ward boys or the sisters who are wearing the PPE should be able to transfer the patient from the OT to the post-operative ward. High quality filter for already intubated patients. So sometimes we transfer the intubated patient with endotracheal tube in situ. So in that case, we need to have filter for already intubated patient, and the patient should be put on N95 mask for non-intubated patients. So don't transfer the patient just without mask, because suppose if they are already positive, while transferring itself, they can infect many people. And two phases of post-operative care: immediate post-operative recovery phase. Close monitoring is required. Of course, saturation, CO2 saturation, pulse, BP, and all vitals has to be monitored, and intensive care to detect early signs of complication. So especially the pulmonary complications are the one which has to be detected immediate post-operatively, so that you can take action immediately. And orders and notes from the ward to plan post-op care. The case sheet and the post-op orders has to accompany the patient without much delay, so that the orders can be implemented. So monitor vitals, assessment of the saturation, keep the patient warm, especially in the post-operative where AC is there, the patient may be shivering. So you keep the patient warm, and intake and output is always mandatory. Protect the airway, keep suctioning with disposable suction, assessment of the surgical site, whether for the bleeding or the oozing, and pain relief. All these add to the good immediate recovery phase. So the phase two is the later on. It doesn't need much intensive observation like the phase one. It is less observation, ambulation of the patient, and monitor bowel bladder movements, early recovery and early discharge. So early ambulation, especially both for laparoscopy and laparotomy, is very important. It reduces the lung complications like collapse, bronchiectasis, etc. If patients are asymptomatic to mild COVID patient, aim is to plan for early discharge and home isolation. Suppose if the patient has undergone minor procedures like tubectomy, DNC, or some other diagnostic hysteroscopy or diagnostic laparoscopy, these kind of patients can be discharged as early as possible. And if they are positive, so you advise home isolation at least for 14 days so that they don't spread the disease to other people. So all of you know that how the SARS-CoV invasion into the host cell. So it attaches to the cell, and it gets into the cell through the AC receptors, and it produces lot of inflammatory reaction inside the cell and produce something called cytokine storm, so which is responsible for many deaths and morbidity and mortality to the patient. So symptoms and lab findings, always fever is the number one symptom. So it is almost always there in most of the patients. Fatigue, cough, loss of appetite, body ache, shortness of breath, diarrhea, all these. So nowadays, any symptom related to any of these mentioned, you must suspect COVID and immediately do the necessary test. Atypical features could be neurological, skin, psychiatric, all that may be there. And on testing, lymphopenia, that is reduced lymphocyte count, is the very characteristic of corona, and elevated liver enzymes, elevated LDH, elevated inflammatory markers, especially CRP, and D dimers values, which says that the patient could be prone for thrombotic events, elevated PT, elevated troponin levels, elevated CPK levels. All these will tell us about the prognosis of the patient. And all this should be done every day to see the prognosis and to treat the patient. So complications, there are any number of. Last year we were not knowing so many complications can happen with COVID. So you can see respiratory complication is the number one killer in COVID. It can be viral pneumonia, ARDS, pleural effusion, embolism, pneumopathy, lung collapse. All these complications can really put the patient. So that is why the oxygen saturation drops, because of the respiratory complication. So inflammatory response, acute liver injury can happen. So that, keep testing the liver function test. Acute cardiac injury can happen, thrombosis of the coronary artery, and myocarditis, etc. can happen. And acute kidney injury, acute renal failure can happen. And septicemia can happen especially the second week of the COVID. So you have to watch for septicemia. And many patients die because of septicemia in the second week, because once they go into severe septicemia, it is very difficult to treat the patient. And after septicemia, DIC sets in, and all other complications sets in, like cardiac failure, pulmonary failure, renal failure, patient become unconscious, etc. So care of critically ill patient with the COVID-19. So aerosol generating procedures, I think Dr. Prakash Trivedi mentioned very clearly. I don't think there is much transmission as believed earlier, that aerosol generating procedures spread the COVID to the medical professional people. But I don't think this aerosol generating procedures are so important. Of course, the smoke evacuation and operating in a closed abdomen is very important, using all the precautions. But I don't worry now much about the aerosol procedures, and reduce all the aerosol generating procedures in the ICU and negative pressure room. So very important that you operate in a negative pressure in the negative pressure operation theater, so that the infection spread is less. And closed and endotracheal intubation to be performed in the closed box. So what you can see here is our box, which is and we request all the anesthetists to perform this to use this box while intubating the patient. And pain management, of course, you have to assess while giving the painkillers for the better outcome. So hemodynamics is very important. Patient with COVID can go into shock anytime. So measure the skin temperature, capillary filling time, lactate levels, and for resuscitation, use always crystalloids like saline and ringer lactate, and don't use agents like albumin, etc., because already there is coagulopathy is setting in, which may worsen by the albumin and other drugs. And if the patient is in shock, norepinephrine is the first choice, and avoid dopamine for renal protection, only to be added in patient with cardiac dysfunction. So avoid dopamine because it is renal toxic, and it is good for the cardiac, but it is not good for the renal function. And arterial catheter as soon as practical. Corticosteroid therapy, as soon as the early shock sets in, it is important to use the steroid therapy to reverse the shock along with the appropriate antibiotics, so that the patient recovers. So oxygenation and ventilation, acute hypoxic respiratory failure, high flow nasal cannula. I think nowadays the people are intubating the patients lesser and less. So it is either nasal cannula or the CPAP, which we use in our hospital for most of the patients. So which gives good oxygen saturation and positive pressure ventilation. So persistent hypoxia where ET not otherwise recommended. So even abroad, many patients, many pulmonologists nowadays, they are not recommending intubation for saturation like 85 or 80 like that, because the intubation itself can produce certain complications. And low mechanical ventilation, low tidal volume, and pressure of less than 30, restricted fluid balance is very important. In moderate to severe ARDS syndrome, it has to be high positive end pressure, mechanically ventilated adults with refractory hypoxemia, and intermittent bolus of neuromuscular blocking agent facilitates and prevent the lung ventilation, because otherwise the patient will be struggling, and that can produce additional problems. So ARDS, all of you know, because of these inflammatory diseases and the cytokines, chemokines, and all the factors can produce acute respiratory distress syndrome. And it is one of the commonest killers in COVID patient. It is the respiratory ARDS is the one which kills the patient many times. And patients on mechanical ventilation and severe ARDS plus hypoxia, the patient must be before pulmonary recruitment maneuver. And I think this is beyond the ICU people, colleagues, and respiratory colleagues should be able to do all these things. We need their help to do setting the pressure of the ventilator, speed of the ventilator, so etc. But I know we can learn a lot by observing them. How do they manage the breathing and the pulmonary function post-operatively? And of course, the CT scan plays a very crucial role both in diagnosis and in prognostication. So you can see the various pictures of the patient. This is the early involvement of the lungs, and totally it has become white. And after therapy, so it becomes better. So it helps in both diagnosis as well as prognostication. And cytokine storm, as I mentioned, well, it is a multisystem inflammatory syndrome in adults, and of course, it can cause the same problem in children. I think they are telling now. So the first wave attacked the elderly people. The second wave is attacking the younger people more, 30, 40, 50, etc. And the third wave is going to come, which will attack the younger generation children. So hence we need to be very careful in these kind of patients. And this is the coagulopathy. Coagulopathy is the biggest killer of in COVID. So it is hypercoagulable state, sepsis-induced coagulopathy, DIC, microangiopathy. All these four factors put together produce coagulopathy in these patients. And coagulopathy of the coronary system can produce myocardial infarction and sudden death, and which is very important in young patients. Many young patients die because of the coronary coagulopathy and myocardial infarction. And thromboembolism. So it is very important that we give post-operative thromboembolism prophylaxis. So nowadays, oral tablets are good enough. The oral new generation anticoagulants are very good, and they don't have much side effects. So it is a very good prophylactic dose. You can give even up to 1 month to prevent the thromboembolism in COVID patients. And also special consideration during pregnancy and lactation. So the pregnancy itself is a thrombogenic status, both the immediate post-operative delivery, whether it is cesarean or normal delivery. So anticoagulation therapy is required during labor and delivery, and to follow same guidelines as in pregnant patients without COVID. So like a high-risk pregnant patient with thrombotic predisposition. So we need to treat these patients with a good anti-thrombotic agents. Otherwise, thrombosis once sets in, it is very difficult to reverse the thing. And you can see here the thrombosis of the inferior vena cava and a big clots everywhere, which produces a lot of damage to the end organs. And say acute kidney injury is another important killer. 22% of the deaths may be due to kidney failure, bacterial superinfection, associated pneumonia, renal hepatic dysfunction due to COVID-induced cardiac dysfunction, and myocarditis. So this is one of the worst prognosis, which carries worst prognosis. Once myocarditis sets in, you cannot do anything. Other ICU complications, nosocomial, and the relatives, like 4 or 5 people, they try to just get into the ICU and post-operative ward. So please don't allow them to come inside. So at least one patient, one permanent bystander has to be there, and whose COVID test is done. And as Prakash said, the food, coffee, and all other things should be provided them inside, so that they should not be allowed to go outside infrequently, but transferring the patient to many people. So post-intensive care syndrome, it is a cognitive, psychiatric, physically disability that affects survivors of the critical illness and persists after the patient leaves the ICU. I have seen many patients, once they recover from the ICU extubation, and once you shift them to the ward, they will start psychiatric symptoms. Why I am alive? It's sort of encephalopathy-like syndrome. They will start saying that, doctor, why did you save me? It was better that I died rather than leaving. That kind of symptoms they will start telling, and you have to differentiate between a real CNS involvement or a psychiatric symptom in these patients. So it produces, so it needs long-term psychiatric assessment and the support from the psychological team to support them. Otherwise, like, you cannot just leave just because they became negative and cured of the disease. And these are all the sleep disturbance, insomnia, anxiety, delirium, microvascular thrombosis, hypoxic ischemia. So all these things can put the patient into miserable condition, even post-operatively or post-COVID for many days. So one has to follow them up very carefully and see the status, their and medical waste management is very, very important. So all of us know what are the things to be disposed in yellow, what has to be disposed in red and blue, etc. So these has to be strictly followed, especially the residents. They, they are little careless about putting these into these boxes. So we must tell them that how important to follow this guideline, so that the COVID spread can be advised, spread can be minimized. So discharge advice and follow up home isolation. Now, once we discharge them from the hospital, they should be there for home isolation if they are positive, with recommended drugs, and anticoagulation is a must in this period for 14 days, and some people recommend even up to 1 month. They must have pulse oximeter at home with a fingertip, and if necessary, CRP, chest X-ray. So they can be done on outpatient method. And 6-minute walk test to check for cardiopulmonary exercise tolerance test. So you tell them to walk vigorously for 6 minutes, so that if they don't get breathlessness, so we presume that cardiorespiratory function is good. Unmask hypoxia to measure every day. You tell the patient to walk for 6 minutes and see for the saturation. If it is dropping, that means that there is something so which need further investigation. So and also follow-up visit should be limited to only essentials. Don't call them for small things, because there will be COVID positive patients in the hospital which should not be exposed to again. And telemedicine and our mobiles are of great help in this age, where to communicate with the like our colleagues, pulmonologists, relatives, and especially the video calls and telemedicine through the laptop and the computers has helped a lot for the communication and to treat the patient. And there is a myth that after the COVID surgery or COVID recovery, the RT-PCR has to become negative. So no repetition of RT-PCR is needed. So your clinical judgment and the patient other investigation is quite sufficient, because RT-PCR may take long time to become negative. So it should not be considered as the active disease. So home isolation is very, very important. Maintain adequate hydration, lot of water, and SpO2, measure BP, and 6th-hourly cardiorespiratory test. And dangerous signs are breathlessness. So that is the first sign of danger, and heart rate going up. That is the second danger. SpO2 less than 94 is again a dangerous sign. And if any of these serious signs are detected at home, you shift them immediately to the hospital and take the opinion of the pulmonologist or COVID specialist. As a gynecologist, we need to learn a lot in the systemic management, and it was a great opportunity for all of us to learn the system, how to manage the systemic disease and the respiratory system, especially. Otherwise, we were confining only to the abdomen all the time, abdomen and pelvis. So now we are exposed more to the respiratory system, cardiac system, CNS, etc. And we have guidelines from our university. So this is the guideline how to follow up the patients who are in home isolation. And these are all the challenges and restricted manpower in the COVID area, and the importance of routine 2 COVID test. So for almost since 1 year, so we don't depend upon one RT-PCR test. So we do one RT-PCR test 1 week previous to the surgery and 48 hours before the surgery. So which makes you doubly sure that the patient is COVID negative. And semi-urgent surgeries can be performed safely 2 to 4 weeks after. Suppose if it is an elective hysterectomy, there is no urgency in this COVID time. So you can call them, put them on progesterone if there is a bleeding, and call them after 4 weeks for effective surgery, 4 or 8 weeks. And CT chest, so suppose if the patient, if you are doubting anything, so if the even if the RT-PCR is negative, doing chest, CT chest is a very efficient tool for even in the post-operative period to detect any early infection with the COVID. To be with advanced age and medical comorbidities like diabetes, hypertension, cardiac disease, so one has to be very careful and consult the appropriate consultant. And laparotomy versus laparoscopy, as all the previous speakers mentioned, laparoscopy scores over the laparotomy because the contamination is less. You are operating in a closed space. If you take if you prevent the spillage of the gas into the operating room, and use of filters and sodium hypochlorite solution in the suction boxes, and dispose of all the materials, wastage, etc. properly, definitely laparoscopy. I remember when COVID came, so even for ectopic, they stopped doing laparoscopy, saying that there is aerosol production, etc. So now it is beyond doubt that laparoscopy has a great advantage over laparotomy because the field of exposure and the exposure to the operating team is less when compared to laparotomy. And smoke evacuator, this is one instrument everybody needs to have. But otherwise also, like in rural areas, I have seen many patients without smoke evacuator. They do in a tight compartment with connecting to the one of the trocars, the suction filter and hypochlorite solution, you can manage well. But if you have a smoke evacuator, you can allow one of the assistant to keep on pressing the button so that whenever there is a smoke, immediately it gets evacuated. And of course, OT fumigation between each case is very, very important. Instrument washing and handling of patients and relatives is very, very important. Single relative per patient, this is most important point. Don't allow more than one patient, however close they are or however BIP they are, because that is the troubleshooting point where, like the spread is more. And disposal of the waste, including PPE fluids, is very, very important. So precautions, all these are the precautions. The COVID positive patient should be isolated and evaluated, and healthcare workers must do post-op rounds with PPE, and you must, even the negative patient has to be treated like a positive patient. Then only the prevention of transmission is possible. So friends, it is our fight together to make this pandemic as an epidemic and then reduce it to our endemic status. So the idea is to now the pandemic should, it will peak up this month. So by hopefully by next month, it will go down and finally become endemic. And I pray God that let the third wave will not come after the second wave. And I pray God, please save all of us so that we can live little more time in this world and see good time in our. And I thank immensely our Dr. Priyanka, our fellow, who has done wonderful job in the preparing this slide and with the COVID patients. So thank you very much, Prakash and Madam Alka and Dr. Nilesh and everybody for your cooperation.
Thank you, Ramesh sir. It was a wonderful talk. Can we have comments from Alka madam?
Well, I learned a lot, and I hope that everybody, and it is need of the day and hour that we are updated on various aspects of COVID. And I hope and pray whatever these people have taught. Presently, we are not operating, not doing elective surgeries. And once it opens, we are able to make use of all these pearls of wisdom which have been taught. And in emergency situations where we are still operating, it is of these points are of great use in day-to-day clinical practice.
Nilesh, I will add two important points.
Yes, sir.
Everybody whom we are operating, when they are discharged, obviously they may come for suture removal, etc. Your follow-up remains till at least 15 days plus. So you have to see that you've operated, everything is fine, and nothing is carried from your hospital, because they can have something outside. That is point number one. Point number two, I think so, Dr. Sangeeta may be aware. I, there are many patients, little bit elderly, they need a lung transplant. And the elderly patients who need lung transplant, and something which Ramesh mentioned, I've interviewed 15 patients who were in ICU, and I've just recorded, means I've gone through what were the feeling, and they almost felt that they were almost at the doorstep of Yamraj, and two bodies going in front of them. So that trauma is too much. So I think so less people should face those days, when we have to understand collectively how to find a solution. Thank you.
Thank you, all the eminent speakers. We had a wonderful session going here with the opening batsman as Prakash sir, wonderfully given his talk. The anesthetist perspective being given by Dr. Sangeeta Shetty, who is doing wonderful work in these times. And as usual,
I have a question.
Yeah, sir, we are taking up this question. Please, sir, go on.
Dr. Sangeeta, we
Yes.
can see the beach and all the things behind. Where is this place? Is it Mauritius or India?
Yeah. This is just my imagination, sir. This is all virtual.
So nowadays we have everything virtual.
Yeah.
Sir, the first question is for Prakash sir. Like there is fear associated with COVID and the surgeries, whether we should do or not to do. Again, there is a difference of opinion. Nowadays, as Ramesh sir said, you said that the safety is improved and there is no much increased risk in laparoscopy as against laparotomy. So what are the extra precautions we need to take to reduce the risk of fear associated with the aerosol generated by CO2 gas? One question. And second question is both Ramesh sir, and you can take this, is what are the medical legal implications, if any different consents you are taking for before doing any surgery in these COVID times?
I think so the questions are very good. Now first, you have to remember what oath you had taken when you became gynecologist. The oath we had taken that we will take care of the pregnant lady or the patient who delivers, who aborts, etc. etc. You can't say I've joined army, but I don't want to go to the front. So that's point number one. Second point, large number of people where I would say they were traumatized by opinion given by people who were not expert. So obviously in the starting we reduced evening consulting because that was a little time. But then I started understanding. I read one book on COVID starting at 3 p.m., finished at 3 a.m. Then that way I read 2-3 books, then interaction. So I think so you have to go deep into the disease. So you can kill your fear by understanding. So from the starting till now, there's nothing like a total close down in our place. So we have methods of, so we have made ourselves very clear. We'll identify that majority of us are COVID negative. We'll also identify that the group of people we are taking are COVID negative. Because all these people, I hypothetically say somebody has early cancer of the endometrium. If she would have waited for 9 months, COVID second wave has come. She will have to wait again. So you have to decide. And primarily as obstetricians, I was very shocked when suddenly we had higher number of elective abortions, which we had to give services. So basically, number one, you should not have tremendous panic. Because that panic, many people closed their hospital, went to hill station, went somewhere else. I know about one of my staff who was panicked the most, and everybody else came, but he was the only person who got COVID positive way far in Dombivli. So basically, you have to understand the disease, you have to take precaution. You cannot be careless. But you remember, somebody is bleeding for fibroid, which is bleeding phenomenally. She comes from Dubai. एक तो मुश्किल से दुबई से इधर है, somebody comes from Oman. So you have to have your proper method by which you evaluate, you get all the tests done, you do a safe surgery, you send them back, and as I told you, you have to follow up them for 15 days at least. So see that there is nothing, because at the end of the day, you get tempted, let's do an antigen test after 15 days. But if you do that and it is positive, they feel they've got it from the hospital. So first, understand the patient, understand the urgency, tell your staff not to worry, give them good educational talk. There are a lot of talk on our website, which is on English and Gujarati. So once they see that the captain is in confidence, you imagine women's healthcare cannot stop totally. So we have to take that much care, wherein we are sure that we can take care of that. With Sailesh, we did one bowel resection laparoscopically. 5 days back, I did uretrovesical anastomosis, everything managed, counsel to the patient. So you have to be sympathetic with patient. Now, accidentally, I had one gynec whose wife was positive and gynec was positive, who came for delivery. And nowadays, this we are going to face more, because there are many patients who are having COVID positive at 5 months, 6 months. So you tell them to take necessary precaution. Don't tell them that we are not going to touch. If somebody was COVID positive next to delivery, I tell that we are not handling, but I will direct you where you have to go. You spend 2 hours, 2.5 hours, see that she is gone to the right place. So it is not that complete no, I will not touch, complete no. And there are risks. There are so many doctors who have got, there are so many people who have got, and it depends on, see, as an entrepreneur, you can control many things within your center. Suppose if you're corporate, like Fortis is corporate, Ramesh himself is a corporate, Alka was always a corporate. So the corporate generates what is to be done, and the big issue there is they have COVID positive and COVID negative patient both. And to segregate staff totally in such situation, it is impossible.
And my second question was any documentation which we need to improve
Yes,
for COVID-19?
You have to take that we are aware that this is going on. Very clearly it is written that everybody in our staff is having tested. There is no, your test is negative. You carry a little more risk than other, and then non-COVID time. But the procedure which we are undertaking, we do with all meticulous care, and none of our system is promoting any imaginary COVID. This is the word which we write, because all the things are imaginary. For example, in peritoneal cavity, if you go, COVID is engulfed by macrophage. Macrophage cannot go to the peritoneal cavity and tell, oh, now you open up, I want to spread. It is only if the bowel is open. So it cannot spread in that fashion. So you explain to them, you give them confidence. And the only thing what I tell them positive is, okay, look, this is a good time. Roads are empty. Doctors are available. Anesthetists are available. We are not supposed to go to too many places. So maybe if your problem is more than semi-urgent, we treat it. But we have to treat it, add on, take an additional consent, like the uretrovesical anastomosis, we had to take ultra high risk, but she went home within 3 days. Right. You may not be lucky, sometimes somebody develops positive after 7 days, but that is what I'm trying to tell. 207 are only endoscopy cases. I have not taken into that deliveries, abortions, DNCs, other cases, IVF. So if we didn't have a single one, maybe we are praying too much, or maybe we are not scared that much, but most important is we are taking proper care to make people understand and take that much load which you can possibly take to take care of the need of the patient. And third, last thing you remember, there are many hospitals I have seen, they have stopped making payments to their staff. lot of staffs have gone. So you have to understand that if you are the single captain, you have to take care.
Yeah. Thank you for your words, sir. I think that was very important that we don't at all completely shut down, and we have a selective approach, elective approach to all this pandemic. Can Dr. Rupal have the next question?
Nilesh, I think about the medico-legal thing, I think he was mentioning about the medico-legal. Luckily, all the medico-legal cases have come down during COVID time. We are not seeing much COVID, like it may be in the media. So we are very lucky that in spite of all these problems, the blame is going to some other people like a politician or oxygen vendor, not to the doctor. That way, we are very lucky that we are facing less medical legal problem. That doesn't mean that we should be careless. We have to be careful, and information to the patient is very, very important, as Prakash mentioned. And also, they are becoming COVID positive after visiting your hospital. Then that may create some problems. So that one has to be very careful that how to handle that situation.
There is one question for Dr. Sangeeta. Can we use only regional anesthesia even for laparoscopy? This is question from audience.
So that is a choice of the anesthesiologist. There are centers where laparoscopic procedures are definitely performed under regional anesthesia. So under spinal anesthesia, it definitely can be done. The issue there is, like I explained in the physiology, that the patients will have certain degree of discomfort, and there can be a shoulder tip pain, there can be difficulty in breathing as the diaphragm is pushed upwards. And then if it is causing a straining and difficulty in performing the surgery, then the benefit is lost. So at our institute, we don't really do any laparoscopic procedures under regional anesthesia technique, but that does not mean that it cannot be done. Definitely can be done.
Okay.
Rupal, one very important thing, the anesthetists which I mentioned, forget about COVID time. He says in non-COVID time, in the city of Bombay, 5 to 6 out of 10 people do laparoscopic surgery under spinal anesthesia. And the logic given by them is, it makes slight difference. And in any case, we are going to finish within 1 hour. So there is no scientific logic given by that. And then sometimes the anesthetist holds the camera also. And the only thing I can remember at Jaslok, we had Dr. Rajam. So we used to have a combination of GA plus epidural, which was fantastic because the bowel spasm used to take place. But only there are many, why I'm telling you, there are many people, forget COVID, there are many people doing. But if you are in places like Ramesh's, mine, or you are at Fortis, or you are Rupal at your place, Alka is at super places only. So I think so we have to understand that general anesthesia with great anesthetists and good setup is not a problem.
So I think we congratulate all the organizers and even the faculty who have been participating. We have more than 8,600 registrations and more than around 2,000 live viewers right now who are there for this program. So this is, I think, a wonderful response to all this conference. The next question which is there is that there was a asymptomatic COVID positive patient who is taking antenatal treatment, and her delivery or a C-section is due in next 15 days. And 15 days prior, she was COVID positive, but asymptomatic COVID positive. So now she's out of her home isolation. Whether to treat this patient in the routine setup or whether to send this patient to a tertiary care or a COVID center. That's the question.
I think if she is asymptomatic and we can do the COVID test, RT-PCR and the other test, and she can be See, even if the RT-PCR is negative and asymptomatic, it is better that you treat the patient for 2 months as COVID positive, because still they can transmit the infection. And so immediate post-COVID, I would prefer to send her to COVID place rather than in a non-COVID place, and for 2 months treat her like a COVID patient.
There are two important things, Nilesh. In the second wave, we have 6 patients who are pregnant and have COVID. In fact, one of the last hysterectomy which I told, incidentally, husband was COVID positive and we were discussing about insurance. Incidentally, he works for Adani, earlier for Reliance. So whatever expense the husband had of 5 lakh rupees was quickly passed, because in COVID, the clearance is fast. Wife's hysterectomy I did. Now anybody who is incidentally COVID positive, and we have 3 people clearly, all 3 from Alibag, who were positive at 4 months, 6 months. So I think so you tell them to have proper quarantine at home, whatever medicine is to be taken, you give on your lookout, you interact with few people. But say if they, say for example, somebody had COVID on 10th of April, which was asymptomatic. Now, how do you know that? Because they must have done some test. So anybody who has done, you do their entire family minimum antigen test. So you know that the whole family is affected, number one. Number two, after 2 to 3 weeks, we all know that if there are no other parameters which are raised like ferritin or D-dimer or many other tests which we do as a routine, I will always tell them that when it comes, maybe your delivery is 1 month later, we'll do at our own place. And we have done many of these deliveries. The reason for that is 2 issues. Once they don't go to a so-called COVID hospital, they're assured about 2 things. One is a big bill. That's point number 1. Second is they don't know who is the obstetrician who is handling. And third is whether needed or not, it is mostly a cesarean section. So it is only if it's a COVID positive or just recently COVID positive, then you send to a COVID hospital. But otherwise, if your own antenatal patient and at least cross a month, of course, somebody can get it again, but they feel comfortable and they feel good, you know, that we had a couple of patients, as I told you, this gynec doctor who was positive, wife was also positive. They told that the sonologist was positive. When they came to us, then our sisters were smart. They found that both of them were positive at 4 to 5 months. But we went ahead and we delivered. So once the phase is gone, as Ramesh was rightly mentioning, you cannot keep repeating. But if there are no other symptoms, she's quite all right. You can deliver at your place, because the number of deliveries during this time, if somebody was having 100 deliveries, they will have now only 25 deliveries. So I think so you can give a better care. Maybe you can keep it a little different room. Of course, every patient is in a different room. But don't send to only COVID. Unless positive, you don't entertain, because you will have to stop your hospital.
Yeah. So, Dr. Rupal, a few more questions. It's 5:47.
So we will take only 2 or 3 questions now. So my question to Dr. Ramesh sir, that only RT-PCR will be okay, or patient should all patients undergoing major laparoscopic surgery should advise HRCT too?
Yes, if the patient can afford, it is better to do just CT along with RT-PCR if the patient is affording. If the RT-PCR is negative and all the antibodies and all other tests are negative, chest X-ray we manage for almost 1 year. We are managing with chest X-ray alone if all other tests are negative, with the clinical examination and fitness from the physician. So that depends upon the patient profile and the affordability of the patient.
Right. Yeah. And one more question is for Dr. Prakash Trivedi sir, that can energy source be the risk for potential transmission?
Yeah. Now, first, what Ramesh answered, I have a very important message for everybody listening. uh, when RT-PCR is positive, you are not going to do anything. She's not symptomatic. There are no respiratory. That 6 minutes walk and all they tell that in 6 minutes your SpO2 is not going. HRCT may not be compulsory. But if they have an HRCT, the importance of HRCT, I'll tell you. If the score is 7 or 15, then that patient is very infective. If the score is high, then that patient needs admission. This is the inference which you have to remember from HRCT. If your score is less or low, we sometimes feel, oh, your score is 710, relax. No, she's going to infect more people. If the score is 20-25, in any case, they will need. I don't do all these 207 patients of laparoscopy. We have hardly done 1 or 2 HRCT because we have the RT-PCR person comes regularly, almost 5 times a week to our place, and we check it with that. Smoke is a myth because a harmonic which generates so much of temperature that your when it touches you, you get a burn. So as such, the virus, and this virus needs a cell. So it is not a free virus. So any heat will kill the virus. Then the smoke is there with CO2 laser also. Everything has a smoke. So you may use a smoke evacuator, but the problem with smoke evacuator, what I was trying to tell, is that they're very small. Now imagine you have an ovarian cyst of 28 centimeter. So you will take the smoke out, you will take that fluid out. So you have to have a big container like the endomat. The smoke evacuator is very small. So basically smoke is not dangerous. Spreading of the smoke by open surgery doesn't spread, but to contain smoke, laparoscopy is better, and have the smoke evacuated through one of the port, either through a smoke evacuator. Unfortunately, this is not a commercial statement, but my statement is smoke evacuator is a waste of money. You can just connect a tube. You have 3 ports. You can connect a tube to your normal suction dipped into, because this was the same smoke evacuator given to me at 1/3 the price in 1995, free of cost, for CO2 laser. So you have to just understand that there is some amount of trade which gives you a false sense of security.
Very true.
The
Yes, sir.
question to Dr. Sangeeta, madam, is that in COVID positive patients, are you doing willing to do a laparoscopy in such cases, or you deny such cases? And if the patient was COVID positive previously and the lungs were compromised, had a moderate disease, uh, at what period after the COVID positivity are you allowing laparoscopy or general anesthesia if it is an elective case for such patient?
Yeah, so the way we are doing it is that we keep it very simple. We just refer the patient to our infectious disease department, because finally there has to be a protocol that is laid down, and the patients have to be given an okay signal by the infectious disease department. But by and large, what we are seeing is the way Trivedi sir was saying, that you definitely, even if a patient has had COVID in the past, the patient would have to have a repeat COVID done. And if the patient is still having certain residual symptoms, then again, there may be a role of a HRCT there. There would be a complete clinical evaluation. We would make the patient do a 6-minute walk test. Very often we do find that patients barely can walk for 3 minutes. So, there is no question that they are going to be able to tolerate any form of surgery. It's irrespective. So more so with laparoscopy, because the hypercarbia, they are just not able to tolerate that. So these patients would not come in for, elective surgeries at all. If there is an emergency surgery and if you have to take it up laparoscopically, then that is a different question. We would have to explain to the patient the risk of requiring ventilation post-operatively prolonged. because often these COVID patients that recover, they are very, very weak. They themselves may take a long time to come off the ventilator. So it is very uncommon to see a patient who has a moderate sort of residual COVID and is coming in for a laparoscopic procedure. This is probably an imaginary situation. So we very often don't see that, but we do see patients coming post-COVID, and there are too many permutations and combinations now. You have patients who are vaccinated and then who have developed COVID, and then they are having a very short period post-COVID and they're coming in for an emergency surgery, and we are taking them up. But we will be doing the clinical evaluation, we'll be doing the 6-minute walk test, we'll be evaluating what their saturation is, we need to know what their ABG is. So that becomes standard then, it would be like any other evaluation of the patient for anesthesia and when we take the patient out. So, but the final word would be with the, from the point of view of COVID and from the point of view of infectivity, because this patient is going to be in the hospital. So we need to know where this patient will be going. That triage continues even post-operatively, whether we can actually let this patient go off in the ward, or will the patient require, even the ICUs are separate. So we cannot just let them in into the common ICU. So that thought process is, it is a very broad-based thought process that we have to do whenever we are considering to take up these patients.
Nilesh, can I simplify your question? You are on mute, Nilesh.
Sure, sir.
Yeah. Now, say my close relative, hypothetically my sister. I have operated my wife, I have operated my sister, you name my daughter, everybody. Now, say for example, there is a CS cervix, which is operable. She gets COVID. There is not much of comorbidity. Many BP, diabetes, many people have, but didn't need ICU and many other things. She comes back. Now she needs surgery because you want to remove because it is cancer. Now she was COVID, so you're aware. So I think so, as Sangeeta and all these people in intensive care. So you have a patient who had been in ICU and various parameters were done. So if somebody's various parameters were altered, then that case is different. But I'm talking about now, my sister is somebody's sister also. So she has a cancer which can be done laparoscopically, which can be done open surgery. Now, if she had COVID, she had home quarantine, she took some standard treatment. She didn't have to go to an ICCU. She recovered. Then you will evaluate through an intensivist all the parameter and still will prefer to do her laparoscopic surgery for radical hysterectomy. Not necessarily I am doing. I will do with somebody who does 25 minutes faster than me. That's point number one. The same patient, suppose, for example, it is on a border like 2B or 2A, and there are other associated issues, then it clearly becomes that it may be a COVID surgery and probably an open cancer surgery. But still, if the morbidities of COVID are gone through, you start thinking them. And what she see in many places, in Fortis, you have everybody, good anesthetists, good setup, good pulmonologists, good ICCU. So many factors are there. So you can have your patient properly evaluated in such place and then decide what you can do it. We did a bowel resection, as I told you, which was around 27 centimeter of bowel resection of an incomplete cancer surgery. Obviously, we did it laparoscopically, but Sailesh Puntambekar was together because there was no point in me trying to do some acrobatics. So basically, you have to understand COVID, what all things it can disturb, ask to an expert. If they find, okay, all those things are gone. So now she is a patient who is COVID, maybe a little bit immunized, some parameter may be compromised. You can do many things. You can do so many tests and see other tests are fine. Refer to a pulmonologist, intensivist. They say you can go ahead with surgery, lapro or open. Then you can decide.
So thank you all respected faculties, the chairpersons, Alka Kriplani Madam, Dr. Atul Ganatra, who in spite of being a family emergency came for the program. Thank you so much. And our esteemed faculty, Dr. Prakash Trivedi sir, Dr. Sangeeta Shetty and Dr. P. Ramesh from Bangalore, who have joined this and made this discussion a wonderful one and given deep insights into surgery associated with COVID-19 in the COVID-19 era. So thank you, everyone. Last words from Dr. Rupal. I think she's lost a connection. So I would like to give the vote of thanks to the team FOGSI, who has been instrumental in initiating this event. FOGSI President Dr. Alpesh Gandhi and Secretary General Dr. Jaideep Tang for making us the coordinators and conveners for this program. And see you tomorrow for another wonderful session with this COVID-19 and Women Healthcare Initiative of FOGSI. Thank you.
Nilesh, the message is take care, stay safe, but treat women. Treat women. We are gynec and obstetrician. Treat women. Take care.
Yes, sir. Thank you. Thank you, sir. So you can download your certificate on whenever whosoever has logged in from the viewers link, they can go to the viewers section and download their certificate by clicking on this link which is shown in the picture. Thank you.
Present in over 70 countries, with 10,000 plus employees, 9 world-class manufacturing sites. Research-driven company with complex R&D capabilities. More than 500 qualified scientists. 13 chirally pure molecules. 5 biosimilar. First in India innovative products. MCure's mRNA vaccine phase 1 trials have started with funding from Department of Biotechnology, Government of India. MCure corporate initiatives. M Gurukul, India's first mentor-mentee program for doctors. Uncondition yourself. First of a kind revolutionary talk show on women's health. M Vidya, a knowledge enhancement series for nurses and paramedics in collaboration with Symbiosis College of Nursing, with 12,000 plus paramedics across 3,500 plus nursing homes. M Diva, MCure in association with RSSDI aims to promise better women healthcare in India. AnemiaFreeIndia.com, an initiative of FOGSI and MCure to spread awareness about anemia in India. Stroke Care App, an app towards stroke awareness for patients. BreastfeedingIsGood.com, an MCure initiative to promote breastfeeding awareness in India. At MCure, science wins.
When was the last time you heard women openly talk about their mental and physical health? Menstrual disorder, diabetes, pregnancy and breastfeeding, depression, cancer, infertility and safe abortion? Don't remember? Well, that's because the stigma attached to such conditions has forced women to bear the pain in silence. Dismal statistics on women's health need to change. A difference cannot be made until they voice their opinions, put forth their stories, and together bring about a healthy change. Presenting Uncondition Yourself, India's first of its kind revolutionary talk show dedicated to women's health. A platform where we talk about their health issues and breaking taboos. Catch Namita Thapar in conversation with leading doctors and patients, sharing candid stories. It's time to speak up. Together we can raise awareness and create an impact. Subscribe to our YouTube channel for more such videos related to women's health.